All right, guys, today we're going to talk about calcium chloride. And I got to give a little bit of a disclaimer here before we start on this one. I know that most of the time we don't have a central line to give this through, and I'm going to kind of touch on it and why we should do it through a central line if at all possible. There's a much better alternative to this, which is calcium gluconate. Problem is we don't have that on the trucks. Usually they give us the box of calcium chloride. Remember, this is kind of a last-ditch drug, except for maybe in a certain situation of cardiac arrest that we'll talk about. But again, you got to know your ions here, and you got to know what this drug does and doesn't do. Okay, so it's usually it's given to somebody that we know has low calcium. Okay, or that we suspect has low calcium. The only time that we should probably suspect that they've got low calcium is when they're coming off of a dialysis machine. Okay, if they've gone into arrest because of dialysis and they already had their dialysis done, there's a good chance that they probably drew off too much calcium too quick and caused some problems. Okay, so it can be supplied, by the way, in this is the kind of the normal, but I've also seen the vials of it, and it is required on most trucks to be on it for ACLS. But I will tell you, probably in 30 years of practice, I've maybe delivered this 10 times, maybe. So again, your frequency of giving this is very, very, very rare. So again, it causes an increase in the squeeze. Remember when we talked about the schoolyard approach, or the fun with the pathophysiology? Calcium holds the door open, right? So again, this is a good one for the good ion exchange, okay? And it increases the myocardial automaticity. We like that. Okay, so it increases the nerve transmission capabilities. So far, so good. And it does relieve muscle spasms due to low calcium blood levels, like maybe, I don't know, a black widow spider bite. Okay, so again, it's usually a very hypertonic solution and should be given very slowly. I would say even dilute it into a bag and let it run in, and make sure that I had a really good IV going when I did this. A very large IV, preferably in the AC area. The onset of action is 5 to 15 minutes. And again, the duration of action, it's usually dose dependent, but usually it depends on how much you give. It usually is up to 4 hours after an IV administration. So when do we use calcium? When do we use calcium chloride? Again, if you gave too much Verapamil, you gave too much Cardizem, then yeah, I guess it's about time, because those are all calcium channel blockers. It can minimize the side effects of those, and again, we use it as an antidote for magnesium sulfate overdose. And the reason that is kind of important is we start talking about our pregnant patients, and they stop their contractions with mag sulfate, and unfortunately, if they kill the deep tendon reflexes or cause the patient to have breathing problems, calcium, you're going to use calcium, hopefully calcium gluconate is what you're going to use, but calcium chloride can be used to offset that. It's an adjunctive therapy for abdominal spasms when you got a black widow spider bite or a Portuguese Man-o-War, and actually sometimes we'll mix that with KY jelly and place over the wound sometimes, and those do help. Acute hyperkalemia for wide complex bradycardia with a history of renal failure. So if they've got a really high potassium and they're about to arrest on you in really big wide complexes, again, this is the drug that you definitely want to go to, because it's going to counteract the high potassium. It's again going to hold the door open for sodium, so sodium can get in, potassium will go out, hopefully. Again, acute hypocalcemia, again, after multiple blood transfusions. Usually, actually, we give a little bit of calcium chloride after a blood transfusion, especially with large amounts. Trauma that's kind of done. Ain't nobody got no time for that. So, again, biggest problems with this is it's very caustic to the vein, okay? Extremely caustic. And if you give too much of it, bradycardia, they can go into arrest, they can develop hypotension, they can actually go into VFib, again, because you're messing up those ion shifts, and again, you can make the heart very irritated. It might give you a little bit of metallic taste, and again, local, you can have the tissue necrosis at the injection site. if you know that their calcium is high, you don't give it. Kind of makes sense. If they have VFib during a cardiac resuscitation, with one little exception there, again, if they have just come off the dialysis machine, okay? Patients receiving digitalis, okay? Digitalis, if they've got high levels of that, it can cause problems. And again, it can actually shut down the heart. You don't want to do that. And again, if they have known hypercalcemia, we don't want to give it. If they haven't repaired renal function, well, Scott, you just said, if they just came off the dialysis machine, usually they're on dialysis because their kidneys aren't working anymore. Again, it's because they pulled off too much fluid, they pulled off too much calcium, which then stalls the heart to stall. Okay, so again, it's one of the balancing things here. It potentiates digitalis, so if they're on a lanoxin, digoxin, really got to be careful with this. It can antagonize if you've been given Verapamil or diltiazem. It can counteract those. If you give it with sodium bicarb, I think some of y'all got to see that little experiment I did in the lab. We mixed the two together, and boy, it made nice little crystals. It was awesome. Yeah, and that is not very good for the patient, by the way. Again, it's usually a very hypertonic. It should be given intravenously as close to the heart as possible, preferably in a big vein. And preferably in a central line. It really should be given through a central line if at all possible. Make sure that you flush the IV, okay? Make sure it's good and flushed in between giving any other drug, because calcium doesn't play well with others, okay? Large bore and central line if possible, okay? I guess you're going to see a question about that. Yeah, pretty good bet you're going to see a question about that. Again, in patients that are having cardiac disease or respiratory insufficiency, it can cause bronchospasm, so we got to be careful. And if you give it too fast, yeah, they're probably going to go bradycardic, and they can go hypertensive on you if you do that. So be careful with that. And again, it's the antidote again for the magnesium sulfate. I wonder why that's in red. Okay. So you usually give 2 to 4 milligrams per kilogram over 5 to 10 minutes. Guys, usually it's 1 gram that we usually end up giving, okay? 0.5 to 1 gram. Matter of fact, you don't have to push the whole thing usually in even cardiac arrest. For pediatrics, we give 5 to 7 milligrams per kilogram at 100 milligrams a minute. So again, we're going to push this into a bag and run it in and really watch and titrate it, okay? Here's the key thing. It says over 5 to 10 minutes. It's probably a good idea to put this, by the way, if you're going to mix it with something, by the way, it needs to be D5W. Normal saline sometimes causes some issues with it. Again, you can repeat once in 10 minutes, so your maximum dose should only be 300 milligrams for a ped. Maximum dose for an adult is 1 gram. I wonder why those are in red. Okay. Again, it does cross the placental barrier, but again, pretty safe to give to your pediatric patients. We wouldn't be giving it for a mag sulfate overdose if that was the case. And again, IV and IO, and IV being big IV, not in the 22 in the hand. Yeah, you can pretty much kiss that thing goodbye the second you do it. All right, so that is it for calcium chloride. I know it kind of went a little deep there on that one. You're not going to use it too often. Just remember, flush it well, big IV if possible. That's the trick. All right, guys, we'll see you on the next one.